Well, again, thank you, Serge, and the organizers for the invitation. Now, the focus for my talk is really trying to discuss where do we stand now almost 4 years after the approval of Ruxolitinib. Clearly has become the standard of care for many with myelofibrosis. So where is the field evolving in terms of other opportunities? That discussion is really divided between both myself, which I'll be focusing on the specific JAK inhibitors and combinations, and then Dr. Telpaz, who will be focusing on other novel agents. So let's start with a case. 66-year-old gentleman, ET for 20 years, found to have post-ET myelofibrosis, no eligible transplant donor. Very symptomatic, an MPN-10 of 63 out of 100. Spleen is very large, anemic with transfusion needs, leukocytosis, mild thrombocytopenia, 4% blasts, 3% reticular fibrosis, complex karyotype, primary myelofibrosis. Now, if we think about the risk, there's no question this individual has very high-risk disease by all of the criteria that we utilize in the DIPSS risk categorization. If we think about goals of therapy and burden, similarly, many factors to include, and probably should have put an X even in the movement toward AML with the 4% blast. So they're very symptomatic, real spleen-related issues, anemia, and movement towards AML. Now, this individual was begun on Ruxolitinib 5 milligrams twice daily, starting at that lower dose based on the studies done by Mashi and others, showing starting at lower dose in people with platelet counts of less than 100,000 at that time. Now, 2 months later, this gentleman had some benefit. The spleen was a little smaller, still was anemic. White cells were a little better. Platelets were similar. Symptoms were better. The dose was successfully increased to 10 twice a day. Now, 6 months afterwards, at the dose increase, the patient was better. The spleen was smaller, hemoglobin perhaps not as bad, white count a little better, platelets were better, less symptomatic. This is a good scenario that we have for someone who's responded to Ruxolitinib. Now, 36 months later, as we see individuals can have, the benefits now have waned. This individual, the spleen has rebounded somewhat in size. Now they're back to needing transfusions. The leukocytosis is back. The platelets are a bit more severe. And the patient is once again thrombocytopenic. And these patients are out there, and we certainly see them now that we really have a very mature both experience and indication with the use of Ruxolitinib, what to do in the individuals that have more difficult disease. So I'm going to break my comments really into 3 segments. 1, what is Ruxolitinib failure? 2, a specific discussion regarding Pacritinib and Momelotinib as the 2 mature JAK inhibitors in phase 3 programs. And 3rd, a discussion on combination strategies. Now, before I discuss investigational approaches, perhaps I can at least share with you my view as to how I approach patients with myelofibrosis. First, I really try to get an assessment of their risk and their symptom burden. I think both are important. Low-risk patients who are asymptomatic may well be observed, although there may well be roles for intervention in certain groups of these individuals. There are interferon studies planned. There's an interferon study open with Dr. Silver's group as well as with my group. Low risk but symptomatic, these individuals probably have more problematic disease, and perhaps there's a role of a JAK inhibitor or interferon. There may well be trials in the near future of low risk but with higher risk molecular features, as Jamil very elegantly showed in her talk. And again, there may be a role for intervening in those folks. Intermediate to high risk, these individuals, I concurrently set up a visit with myself and my colleague who does bone marrow transplant to somewhat have us really each be a check upon each other. I think individuals that are potentially transplant candidates should have that discussion, as well as a discussion of medical therapy, in part so that we don't excessively delay people who should be transplanted, but by the same token, we don't transplant people in which it probably is not yet appropriate to do so. Urgent allogeneic transplant, we proceed to allogeneic transplant, perhaps with JAK inhibition prior. We have a current ongoing study led by Vikas Gupta with Ruxolitinib prior to transplant through the MPD Research Consortium. Delayed or never for a transplant, let's say age or comorbidities or other factors, really take that off the table to begin with. Or if it's delayed, well, we're not going to do transplant now, but it's going to be delayed. Clearly, JAK inhibition is the standard of care. Perhaps a subset of people who have anemia as a driver, a slightly different path. People who really fail from this group is where I think the clinical trials are the most relevant. Now, as we think about new therapies and trials, what are our response criteria? They are in part our agreement as a field as to markers that are relevant. A complete remission being resolution of myelofibrosis signs, symptoms near normal counts, and a bone marrow appearing histologically near normal. Partial remission meeting most of these features except the bone marrow criteria. Clinical improvement, which is where most agents have met their efficacy, have been around improvement specifically in anemia, splenomegaly, or symptoms, and molecular responses still being speculative as to their value. Now, as I evaluate new therapies, I like to try to look at it really in a holistic approach. We try to think about the patient who is doing better, and recognizing there's many factors in there, so I have it here on the Rubin scale as a smiley face. That is the goal. Now, let's say the patient has myelofibrosis and they have been treated with Ruxolitinib. They have a decrease in splenomegaly, decrease in symptoms, an improvement perhaps in survival. They are better, but they are not normal either. So there is room for opportunity and improvement, and how far up this scale, of course, varies. Now, as we think about expansion of improvement, one, what would be an expansion? Less fibrosis? Perhaps. Decreased cytopenias, likely that would be better. Improved molecular response, perhaps. Or, another part we don't discuss too much, if we could turn that 3-year or median of 3-year benefit to 10 years, that would be a very different story as well. Now, as we try to think about what is Ruxolitinib failure, many trials are ongoing. Many have come and asked me that specific question. How do I define it? And the problem is that it really is somewhat dependent on what is the alternative. In a field where we have really one approved drug, failure is very much dependent upon what is the alternative. The Europeans or the British have a balance that they have used in their British guidelines that I think is the most helpful. And they look at really the spectrum of symptoms, splenomegaly, and toxicity, because really it is a balance of each of these. Even minimal residual efficacy, if there's no toxicity, may be a role for keeping a patient on a therapy. Whereas if there's a lot of toxicity and little efficacy, the enthusiasm clearly is dampened. So, is there a definition for Ruxolitinib failure? There really is not, because it is a sliding scale that truly is dependent upon the alternatives that one has, as well as an assessment of efficacy and toxicity. Now, in the JAK inhibitor space, there have been many therapies. There are therapies at the bottom of this graph, which no longer are in development for issues of toxicity. But the pipeline has been very robust, with the key 3 agents at the moment clearly being Ruxolitinib, which is approved for the 2 indications, Pacritinib, which has completed 1 phase 3 and rapidly accruing the second, and Momelotinib, which is actively accruing to 2 phase 3 studies as well. Others are earlier in development, and given that JAK inhibition may have roles in a variety of other indications, they may still well be developed based on potential activity on anything from pancreatic cancer to even refractory psoriasis. So first I want to focus on Pacritinib. Pacritinib was SB1518. This is a JAK2 and FLT3 inhibitor. I presented these data on behalf of the investigators for the phase 3 study at ASCO, and they were presented by Claire Harrison at EHA. This was a randomized study building basically off of the observation we made in the earlier studies that Australians, Serge and I and others were involved in, the pacritinib did not seem to lead to significant thrombocytopenia and could be safely dosed in people who had significant thrombocytopenia, and that it may have even a beneficial impact on anemia. So on that basis, patients who needed therapy with MF could be enrolled, randomized between pacritinib and best alternative therapy, but very specifically, there was not an exclusion for thrombocytopenia based on this earlier data. Patients were randomized 2-to-1 between pacritinib and best alternative therapy. Patients treated on this study overall had fairly aggressive disease, as one might expect, being enriched for this group that had significant thrombocytopenia, with 16% having platelets of less than 50,000 and about a third having platelets less than 100,000. Patients on the best alternative arm really did not have a lot of great options, and this is not a surprise given the scenario. So individuals were either in a watch and wait mode, a hydroxycarbamide, and many had failed other prior therapies. They were all JAK inhibitor naive. We observed and reported that there was significant reduction in splenomegaly as assessed by splenic volume. The evaluable population, meaning those individuals that had all of the prerequisite scans, showed significant superiority versus best alternative therapy across all of the groups, including the groups with thrombocytopenia. This specifically a drill down on those individuals with significant thrombocytopenia, showing very significant differences between the pacritinib and BAT arm. Additionally, a very significant improvement in the symptom burden was shown for the entire group. As we looked at individual symptoms, which were presented both at ASCO and EHA, we again, and not unsurprisingly, both for this class and consistent with the prior data, showed very significant improvement in the symptomatic burden. Now, the cytopenias were clearly a key driver as to why this study was performed. One, we saw that the prior observation of no drug-induced or minimal drug-induced anemia was consistent in this study, and overall, you see the stability of the hemoglobin. In regards to the platelet count, there was actually a trend for improvement. This could be related to reduction in splenomegaly and other potentially beneficial factors. According to Gale criteria of transfusion dependence, there was a significant improvement in red blood cell transfusion independence in the pacritinib arm versus BAT. The most common toxicities were gastrointestinal. This is consistent with the earlier studies, with the majority of individuals having some GI toxicity. In most cases, these were grade 1 to grade 2, and primarily well controlled with either antiemetics and or antidiarrheal agents. 10% of the patients in the pacritinib arm had dose reductions due to GI toxicities. Discontinuations for this were rare. Momelotinib is in an ongoing phase 3 study. Momelotinib is a JAK2 and JAK1 inhibitor and had earlier studies which had demonstrated the potential to improve anemia. A slightly different study than the pacritinib study which I demonstrated, momelotinib is randomized against ruxolitinib as frontline therapy with response goals of improvements in splenomegaly and symptoms as well as with anemia. This study is ongoing, so I have no data to report. There is a parallel study that is being done that allows individuals to be in second line and momelotinib versus best alternative therapy. Now, what about combination approaches? Well, there are more trials for myelofibrosis at the moment than there have ever been before. There are a variety of drugs in single agent, and I'll leave the single agent non-JAK inhibitor discussion to Mashi. There are a variety of combinations. I will say that they really fall into several categories. They fall into categories of, one, combinations that hope to improve anemia. Let's take drugs that had activity in anemia before, add them to ruxolitinib, see if we're better off. Two, combinations of drugs that are active perhaps against more aggressive disease. We heard earlier today about discussions of movement toward AML. John Mascarenhas is going to touch a little bit on this later in his discussion. Is there a benefit to combination? And finally, a range of alternative targets which are going to be targeted in parallel with JAK inhibition. So one, I'll discuss a study that John and I have been working on together, which in some ways is simple and inexpensive if successful, and that would be the addition of danazol, the androgen agent, along with ruxolitinib in a single-arm phase 2 study with the goal of trying to improve anemia. What we have observed and will be have submitted for consideration for ASH is that danazol clearly does have activity in combination with ruxolitinib. How much activity is a little difficult to decipher, and that the activity, I think, is divided into a couple different camps. One, stability of counts. So if you're on ruxolitinib, there's the normal trend to decrease the counts. If you add danazol, do the counts stay more stable? The people in green, that may well be the case for their hemoglobin and their platelets. The group in blue, which is more modest, is there an incremental improvement in anemia or thrombocytopenia for those who go on the combination? These studies are ongoing to see what would be the logical next step for such an investigation. There were presented at ASH a variety of combination studies, all with interesting preclinical discussions. One, the inhibition of PI3 kinase. These combinations studies largely are a combination of both drugs together. This study was presented at ASH, and they all have a similar theme. These combinations were active. This was a combination that showed significant activity for reduction in splenomegaly with the PI3 kinase inhibitor. Whether it is better than ruxolitinib alone, what is the impact on other long-term issues such as symptoms, survival, etc., we do not know. With all of these combinations, they will have, I think this first wave is really trying to vet for efficacy. The next step, I think, will be more difficult, for the incremental cost, expense, or toxicity of combination therapy. How does a combination therapy really distinguish itself from single-agent JAK inhibition, given that JAK inhibition has fairly significant activity on its own? The second, with panobinostat, parallel studies, both that John and Ron Hoffman have led in the US. This slide is off of the French study led by Jean-Jacques Kilajan, where again, panobinostat plus ruxolitinib. Part of this study's goal was to try to find an optimal dose, given that both have DLT of thrombocytopenia. And again, the agent showing intriguing activity, but the data is early. The ProMeteor study, led by Serge, many of us involved, this agent, a recombinant human pentraxin-2, to try to help to decrease fibrosis. A study was done with the agent alone or in combination with ruxolitinib, helped to demonstrate, one, that there seems to be activity in reduction of fibrosis. The numbers are small and need further validation, but even over a 36-week period seem to have activity. Imaging analysis has been brought into the mix and was presented at EHA, showing some normalization of hematopoiesis or decrease in fibrosis for individuals. This is just showing the computerized morphology analysis regarding fibrosis that's being utilized to try to be a bit more sensitive to the changes. There's also been improvements in cytopenias with this anti-fibrosing agent in regards to individuals with thrombocytopenia. Clearly, the hope of decreasing fibrosis might be improved hematopoiesis and a more favorable bone marrow microenvironment. Other combinations, this is ongoing for people with both the let's say, chronic phase MF, as well as those more accelerated, with LDE 225 and Ruxolitinib. And like the other studies, they all seem to show activity for a combination improvements in splenomegaly. This is Vicus' study, and again, is an ongoing study. They all seem to have activity. They all need, I think, more maturation before we truly judge them in any sort of comparison. And then finally, in terms of combination, this is a study led by Serge. This is Ruxolitinib plus azacitidine. I'll really congratulate his group in terms of exploring alternative ways of dosing these medications together. And they did have a run-in of Ruxolitinib before starting the azacitidine, which may be a very helpful observation in terms of tolerability of both of the agents, as well as helping patients get more accustomed to have the cytopenias of the Ruxolitinib stabilized before introducing the hypomethylating agent. And they presented at EHA activity for this combination as well as tolerability, and will certainly be eager to learn more about this study, I'm sure, at this year's ASH. So I'll conclude by saying that Ruxolitinib failure is really a conditional state that is really dependent upon the alternative options, the degree of response, and tolerability. Pacritinib showed ability to improve anemia and thrombocytopenia in all subgroups in MF, while being safe and effective for those with thrombocytopenia. Momelotinib is intriguing and currently in phase 3 studies. Many Ruxolitinib combinations are under testing. Several really appear promising. I think given the number of combinations, there will be quite a bit of vetting, I think, before any of these really would mature to become a alternative standard of care. Thank you.